American Psychiatric Association 1996 Annual Meeting. Are We Still Talking? Part 1.
Jennifer Havens, and I'm proud to present our symposium today called Are We Still Talking? We have 4 very interesting and different clinicians and writers and thinkers and researchers to talk to us today about various aspects of psychotherapy in the context of modern psychiatry. The format will be each speaker will talk for around about 25 minutes. We'll have a couple minutes for questions, and then we'll move on to the next speaker. And then Dr. Francis, our discussant, will take the 4 of these gentlemen on. First, we'll hear from Dr. Robert Michaels, who's the Dean of the Cornell University Medical School and my first training director. Then Dr. Leston Havens, who's a professor of psychiatry at Harvard Medical School, recently retired from running the residency program at Cambridge City Hospital and now is the director of education in the Department of Psychiatry at Cambridge Hospital and a distant relative of mine. Then we'll hear from Peter Kramer, who is a writer, as he tells me, and we all know, and a psychiatrist, and the author of what was a very important book in our field, Listening to Prozac. And then we'll hear from Dr. Peter Wyden, who is an associate professor of psychiatry at the Columbia University College of Physicians and Surgeons and a local and national expert in public health issues and treatment issues in schizophrenia, who will present some work he and my distant relative of a father did together on communicating with psychotic patients. Finally, we'll hear from Dr. Alan Francis, who is the professor of psychiatry at Duke University and, as we all know, the shepherd of DSM-4. So with that, let's get started. Bob?
I would like to start by thanking Dr. Havens for inviting me to participate in her family therapy here.
No interpretations, Bob.
This talk is going to reflect one of the current dilemmas of psychodynamic psychiatry. I've been given 25 minutes for what normally would take me 50. And if I run over, I have an 800 number I can call up and seek further time. But the person at the other end of the phone isn't listening to the talk. Psychodynamic psychiatry is just 100 years old. It began with the first notion that the mind had something to do with disorders, and that meanings and their understanding might contribute both to a ideologic conceptualization of mental disorders and to some kind of treatment. In effect, that talking to patients, or more probably listening to patients, could at times help them with their problems. Since that time, that theme has continued and forms one of the major themes of contemporary American psychiatry, and it's also differentiated in a number of ways so that subsidiary themes have evolved parallel to that central theme. One differentiation has been to a much broader notion of the disorders that could be dealt with by this particular method. So broad a differentiation that there are very few people who don't look like patients to some practitioner of psychodynamic psychotherapy. In effect, it was one of the most marvelous marketing tools ever developed by anyone selling a treatment. And it's expanded to include newly discovered and defined disorders, non-disorders, and citizens in general. A second differentiation, I think, is quite clear if you look at the history of the field, but usually isn't very well understood by those who write about it at a distance. Psychoanalysis, as we know it today, is only about 70 years old, and was clearly a secondary product. The thing called psychoanalysis that was done from the late 19th century until at least the end of the second decade of this century was far more akin to our shorter-term psychodynamic psychotherapies than contemporary psychoanalysis. It wasn't until 30 years into the history of the discipline that patients routinely came back after their first summer break to enter a second year of treatment. So we'd have to say that contemporary psychoanalysis is one of the children of this original treatment. Thirdly, a great many treatments have been developed out of various components of this original complex mixture of things that go on when a patient and a therapist talk to each other. So that we have treatments that focus. They might focus on the patient's symptoms. that might focus on cognitive strategies or ways the patient thinks, that might focus on relationships or the kinds of interactions the patient has with other people in the patient's life, that might focus on the therapeutic relationship, the experience in the consultation room, that might focus on constructing a story about the past, one of the things that Freud was preoccupied with in the beginning of this field. And so we have symptom-oriented treatments, cognitive therapies, interpersonal therapies, relationship and existential therapies, and victim-oriented therapies that focus on reconstructing stories or truths about the early experiences that are thought to be of pathogenic significance. All of these treatments have evolved and crystallized parallel to the continuing evolution of psychodynamic psychotherapy and psychoanalysis. We see trends today that are interesting. One is a trend of greater and greater focus on the clinical dimensions of this approach as opposed to its metapsychological or theoretical underpinnings. Secondly, technical innovations that in effect make the treatment more user-friendly. Less focus on painful awareness of things about oneself that one doesn't want to know, more focus on the pain and the sensitivity involved in coming to know those things and on the discomfort in the relationship. Modern psychodynamic psychotherapy is more attuned to deal with things that make the process of therapy uncomfortable for patients. Thirdly, a sharp limitation of goals. Very few psychodynamic psychotherapists or psychoanalysts today believe that one should totally reconstruct a story of early life or resolve all conflicts or understand all dimensions of the transference. One of the goals of treatment, very important early in the history, lost in the middle third of the century, and back with us again, is to end the treatment. Fourthly, the content scope of psychodynamic psychotherapy has widened from the original interest with a focus primarily on the mental structures that involve motivations or wishes to much broader interest in other kinds of drives or motives, such as aggression as well as sexual or libidinal drives, self-representations, object representations, and the like. The therapist has a larger lexicon, a larger metaphor book to draw upon in making interpretive interventions, more games to play when with the patient. That's as long a history as you're going to get. Today, there are marked changes in American psychiatry that have challenged the still preeminent but diminishing role of psychodynamic and psychodynamic psychotherapy in the field. It is still the dominant activity of practitioners of American psychiatry, although not perhaps of the most recent graduates of our residency programs. It's facing a major threat from changes in the healthcare system. It's faced a slew of threats before, and in understanding this most recent one, it might be helpful to very briefly review the earlier threats. I'm relying primarily from this point on my memory rather than the history books. One of the most dramatic threats a few decades ago was the challenge from biologic psychiatry, claiming that, in effect, mentalism was imaginary, not real, that the diseases that psychiatry dealt with were biologic disorders, not psychologic disorders. This was a hot issue 40 years ago. It's diminished considerably now. Our newly found discovery of the chronicity of most of the disorders in psychiatry, the fact that they're lifelong rather than acute episodes, the fact that they involve severe functional impairment as well as symptom clusters, has led to a recognition of the value of interactive biologic and environmental and therefore psychologically mediated models. Psychiatry has followed modern genetics in discovering that any powerful genetic theory has to be an environmental theory as well. A second series of attacks, linked to the first but distinct from it, was that psychodynamic psychiatry was not data-based, in no sense empiric, that it was in effect a cult. Each of these attacks, by the way, in my opinion, has considerable validity to it. This one claimed that there were no evidence suggesting that these treatments were effective and that the practitioners weren't interested in such evidence. I think we've evolved on this in part because at least one group of practitioners clearly are interested in such evidence, and there's been some early movement toward agreeing on how one might collect such evidence and some preliminary studies. The consensus at this point is not that we have the data, but that there's no theoretical barrier to collecting relevant data that would be sufficient to be persuasive, and that the early signs are, if and when that's done, there will be information showing efficacy. The question is going to be effectiveness, the value of the treatment in the market, rather than whether scientifically it can be shown to have an effect on patients. A third attack came from the public health frame, and it challenged psychoanalytic psychiatrists for failing to care for our sickest patients. Largely a valid challenge. How could you justify seeing healthy people in your office for years at a time when there were sick people in our great state hospitals who were poorly cared for? However, with the both recognition that the long-term community-based care of the seriously mentally ill involves psychosocial as well as biologic approaches, as well as the discovery of powerful biologic treatments for the less major psychiatric disorders, anxiety disorders, for example, have blurred the sides in this issue. And it's finally been, I think, well put to death by the current concern that we may have too many psychiatrists for the nation's desires rather than too few. I think the current problem in the field is not whether we have too many psychoanalysts around, but how we can develop a training program to train board-certified radiologists and anesthesiologists to do psychoanalysis so they'll have some possible role in the community and the healthcare system as it evolves. A fourth concern comes from a socio-cultural issue. There is huge cultural variation in the utilization of these treatments. The east side of Manhattan and Salt Lake City have very different ratios of psychoanalytic caretakers to potential patients, and this is troublesome to some. Finally, and very powerfully, there's been an important attack on psychodynamic psychiatry from a desirable quarter, modern psychopharmacology. Within the last decade and less than that, we for the first time have user-friendly, acceptable, and effective drugs that are relatively easy for physicians to use and that have a significant impact on those disorders which have traditionally been the major base of psychodynamic psychotherapy. Prozac may have more impact on psychotherapy than it does on patients, but I'll ask Dr. Kramer to speculate on that later. This leaves the latest attack of concern to psychodynamic psychotherapists, the healthcare revolution that we're in various stages of, depending on what part of the country you came to this point from. But before going to that, let me talk a little bit about the status of psychodynamic psychotherapy today. My own view today is that it's a acceptable and valid treatment for a number of Axis I anxiety disorders. I would rule out obsessive compulsive disorder, but certainly psychodynamic treatments have shown to be effective for affective disorders, non-psychotic affective disorders, for panic disorders, and for a number of other anxiety syndromes. Probably particularly effective for mixed syndromes and syndromes that blur the margins between Axis I and Axis II. It remains one of the dominant treatments in American psychiatry for personality disorders. I have to be careful with my precision here with Dr. Francis in the room, but if my memory's right, cluster B and C, excluding antisocials, would be largely the domain of patients who are generally the customers of psychodynamic psychotherapy. It is a major treatment for people who have problems in life, problems in adjusting to stress, to medical disabilities or disorders, compliance problems with treatment regimens, rehabilitation issues, and other life conditions where sub-threshold Axis II syndromes are rate limiting in their happiness or their effectiveness. Psychodynamic psychotherapy is probably at its best with the healthiest patient you can find who yet has some psychological structure that's a problem to him and therefore might be made more effective or more adaptive than before by dealing with that. Finally, it is a powerful adjuvant treatment in combined therapies for the chronic and persistently mentally ill, in assuring that they comply with the entire regimen and in helping deal with secondary demoralization and the rehabilitative problems of such patients. Why then do we have trouble with it? Well, that goes to some of the differences between psychotherapy and other treatments in modern psychiatry. Let me discuss a few of them. First, the indications for psychotherapy are less well defined and particularly less dependent on the patient's diagnosis. in a concept that the late Dr. Samuel Perry developed and explored, the indication for whether or not to embark on psychodynamic psychotherapy is far more relevant to the case formulation than to the diagnosis of the patient's pathology. And that's not the case with most other interventions that we use in modern psychiatry. We're beginning to develop some knowledge of diagnostic-related treatment response patterns to dynamic psychotherapy with certain new dynamic treatments, but we're only at the beginning of that. And most dynamic psychotherapy conducted now is not conducted around diagnostic formulations. In this regard, psychotherapy and its evolution is very similar to the way that pharmacotherapy has evolved. It was only a few decades ago that we had stimulants and sedatives that did not have diagnostic-specific pharmacotherapeutic tools. Our medications have become more specific as we move from bromides to tricyclics and lithium. We've moved from general mood-altering drugs to more disease-specific, disorder-correcting drugs. A similar evolution, several decades behind, is going on in the dynamic psychotherapies, where specific therapies are being developed that are linked to specific pathologic constellations or diagnostic entities. In addition to the indication being less well-defined, the treatments themselves have traditionally been much less well-defined. We're now moving toward attempts to define some treatments through the use of manuals, although with a great deal of concern in the field as to whether the treatment defined by a manual bears important relationships to the treatments that were conducted without the manual. Secondly, it's extremely difficult to predict the utilization of dynamic psychotherapy if you leave the community up to doing its thing. The indications, as I said, are highly ill-defined, and the utilization is highly variable, both in duration and intensity. This is a key problem for those who would manage the cost of health care, because the utilization of psychotherapy is highly idiosyncratic, and to a significant extent, idiosyncratic based on the therapist rather than the patient or the disease. I can give you a better prediction of whether a patient will have prescribed long-term intensive psychotherapy if you tell me which psychiatrist he saw in consultation than if I get to see the patient and evaluate him myself. A third problem for utilization is this is a treatment which is well and easily provided by trained non-physician providers, and it's also a treatment that has high patient acceptability. That creates the danger of a so-called moral hazard of unlimited demand because of the attractiveness of the treatment. In this regard, psychodynamic psychotherapy is similar to Prozac or benzodiazepines in that it's fun for some people, it's easy to prescribe, the dangers are limited, and therefore it could become so widespread that it's like the drinking water rather than a medical intervention. Whether this is good or bad or moral or of concern is an important issue, but the only one I focus on here is it terrifies those that are trying to regulate costs in a healthcare system. A third characteristic, there's less research database for the use of this treatment than there is currently for the use of pharmacologic treatments in psychiatry. In this regard, psychodynamic psychotherapy is far closer to surgery than it is to medical pharmacologic treatments. And it's also similar to surgery in that each episode of therapy has unique characteristics that are heavily dependent on the skills and style of the therapist rather than simply the name of the treatment or the patient to whom it's delivered. 6 people in 6 parts of the country getting penicillin for a disorder get pretty much the same therapy. 6 patients in 6 parts of the country getting Prozac for the same disorder get pretty much the same therapy. 6 patients in 6 parts of the country getting psychoanalytic psychotherapy for the same disorder get 6 different treatments, just as 6 abdominal laparotomies would be different. And the model for research here may be more importantly drawn from idiosyncratic therapies such as surgery rather than standardized therapies such as pharmacotherapy, although that has not been to this point the tradition in psychotherapy research. A fifth characteristic, we have much less quality assurance or peer review here. The schlock factor in psychodynamic psychotherapy is painfully high. Most of us would casually and comfortably refer a friend or loved one to an orthopedic surgeon at the other end of the country to have a fracture set, knowing little more than that they were board certified. Most of us wouldn't think of sending a friend or loved one to a psychodynamic psychotherapist the other part of the country, even if we had their CV and a week to study it. Finally, this area of psychiatry has been stigmatized by the psychiatric profession. In effect, psychotherapy is to psychiatry as psychiatry is to medicine. And if you want to understand the problems of either and you're familiar with the other, that ratio explains them fairly well. Into this world arrives managed care, marked by strangers replacing physicians as the controllers of treatment. The explicit goals are laudable: to raise quality, to save money, and to rationally allocate scarce resources. There's much that's good. It directs attention to our specifying the indications for treatment, the goals of treatment, the methods, and measuring the outcome. It's a wonderful way of countering the inappropriate extension of activities that therapists like to do, regardless of their value or effect. Secondly, it counteracts the danger of exploitation of the patient by the therapist. I believe a significant danger in this area. Thirdly, and potentially most valuable, it provides what psychiatrists are usually loath to obtain unless they're forced to, a second opinion by somebody looking over their shoulder and commenting on what they do. My own experience in psychiatry is the biggest difference between an amateur and a pro isn't what they do, it's how quickly they ask for help and reassess when what they do isn't going the way they want to do it. The managed care process allows forced review at early review points to stop people from continuing to make the same error over and over again. The pros know that if one treatment doesn't work, you switch to another. The amateurs have a favorite treatment and use it and use it and use it. But there are bad things about the managed care world. One is it adds significant expense while lowering total cost. Since it lowers total cost, it's popular to the payers. It's a lower bill. It adds a significant layer of administrative expense. How do you add expense while lowering cost? Well, the people in this room are experts on how to do that. You reduce the price of the purveyor to a lower number. If you pay psychotherapists less, you make enough money to pay huge amounts to administrative costs and have profits left over and lower the overall cost. This has happened in the system. I believe economically it's the inevitable consequence of our being able to overcharge for a number of decades until we invited others in to come and share the pie with us. Thirdly, it leads to a shift from the appropriate prescription to a defensible prescription. If there is a safe harbor, it will be used. If medication is reimbursed and psychotherapy is not, patients will receive medication. Finally, it has a dramatic role on recruiting and retaining members of our profession. I believe that some of our major concerns about recruitment into the profession are more based on the changing perception of the autonomy of the physician or psychiatrist practitioner than they are in anything to do with economics. What's worrisome to students about careers in medicine or psychiatry isn't that they won't make money. In fact, they didn't realize how much they were going to make 15 years ago, and they think the current amount is pretty good. It's that they won't be in charge of their professional lives and won't have the sense of personal autonomy in professional decision-making that used to be part of the myth of the physician. The managed care movement also has some interesting consequences, neither good nor bad, but fascinating. The presence of a stranger in psychotherapeutic relationships is intriguing. I think both potentially good and bad, and should be studied more. The effect of explicit guidelines for treatment, I think, will again be both good and bad and needs to be studied more. I think we're going to end up learning that some patients do better in this kind of system and some patients don't do as well, just as was true in fee-for-service systems, in state hospitals, in community care, and the like. Our traditional fee-for-service outpatient psychodynamic psychotherapy system had serious drawbacks for certain kinds of character structure that managed care can do better with. At the same time, the reverse, I believe, will be true. Finally, let me close with some comments on the impact of these changes on our educational activities. My own view is that psychodynamic psychotherapy is a critical, essential, core educational experience for psychiatrists. My metaphor for it is it's like the autopsy for a medical student. It's a socializing experience into the profession. I would carry that metaphor further and say, like the autopsy, there's no need for a practicing psychiatrist to be competent at psychodynamic psychotherapy any more than there's a need for him to be competent at any one of a number of other treatments that are part of the armamentarium of treatment in our field. A psychiatrist has to know how to meet a patient, assess them, make a diagnosis, and formulate a treatment plan, but we don't expect them to be skilled in each possible element of that treatment plan. So I see psychodynamic psychotherapy educationally as an educational experience, but not an essential training experience, except for those psychiatrists that go on to do it as part of their regular practice. I think that will be some, but not all. I think the more immediate and powerful impact on our field in the short term is going to be the effect on the recruitment into psychiatry if this theme of psychiatry diminishes any further. Why do medical students decide to become psychiatrists? My experience is they're interested in one of a small group of things. Some of them are interested in the brain, and their alternative is maybe they'll be a neuroscientist. Some are interested in the mind, and their alternative is maybe they'd be a psychologist or a philosopher, I guess. Some are interested in society, and their alternative is maybe they'd be a political activist. And some are interested in the specialty practice of medicine, and their alternative is being a gastroenterologist or a rheumatologist. Empirically, quantitatively, we have drawn heavily for our leadership and our genius on those with brain neuroscience interests, and for the mass of our manpower on those with mind psychology interests. A decade or two ago, there was a significant group of those with society political interests, but they've largely disappeared from our current recruitment. At the moment, the attractiveness of the practice of the medical subspecialty is not putting us in an advantageous role when competitively recruiting with other clinical specialties in medicine that don't have the added intellectual excitement that we bring by either brain or mind approaches, and that's hurting our recruitment. I think that this theme of psychiatry has long attracted a special group of applicants, and if it's preserved, will continue to do so for the good of the whole profession. Thank you.
Yes, we can have a couple questions now, and there's some seats up here if people want to try to move people over in the second and third row.
Now, although I agree with you, Dr. Michaels, about several things, which are at least true, but I don't agree with you with. Number one is your view that non-physicians do as well, do therapy as well as physicians. Although it's true that there are some non-physicians who do as well, in my experience and those of many of my colleagues, there are many non-physicians who do lousy therapy, who don't have a clue how to diagnose, who just do the same thing as you say and act like an amateur, although they're supposed to be professional, although they're reimbursed. I mean, in reality, medical leadership is helpful in terms of making a diagnosis and doing better treatment. Now, obviously not in every case, but I think we should not throw the baby out with the bathwater by conceding somehow that everybody else does it as well as we do. The second thing is your concept that the average psychiatrist doesn't have to do psychotherapy any more than he has to know forensic psychiatry once he becomes a specialist. Would be my argument that although there are some psychiatrists who don't, that even if you're going to be a good psychopharmacologist, you have to know something basic about dynamics as well. I've seen many cases where psychopharmacologists have gotten into trouble because they've just tried a whole series of drugs and they've never dealt with the dynamics of the patient's depression. And there's obviously a complex interaction at times, and that drugs alone in many cases aren't enough to do it. And what I would argue this is an essential feature for the average psychiatrist. You could debate that, and the psychopharmacologist specialist may not have to, but the average psychiatrist doing treatment needs to know both.
I think we differ on both. The available data would certainly suggest you can't tell MD psychotherapists from equivalently trained non-MD psychotherapists. I would agree with you that diagnosis and treatment planning should be done by somebody who knows alternatives to psychotherapy, a skill that many MD psychotherapists have allowed to wither. But once the prescription is written, I see very little reason to think that the MD is better at conducting it. In terms of your second question, I think it's an interesting one. My own view is that I'm not sure that there's much more psychodynamics necessary for running a good lithium clinic than a good diabetes clinic. I think there's a little more necessary for the diabetes clinic, from what I know of the pathophysiology of that disorder and the problems in treating it. I think that any physician should have a basic knowledge of human psychology and the doctor-patient relationship for conducting any therapy clinically. But I think the special skills of dynamic psychotherapy are not needed by those psychiatrists who will use other tools of treatment with their patients, except for knowing when to make a referral, which is a skill I would expect any good generalist internist to have as well. We differ.
One more question.
I guess first I'd like to carry on what the previous gentleman was saying in regard to the necessity of a pharmacologist knowing psychodynamic psychotherapy as well. If we consider that non-compliance with medication in psychiatric populations is around 50%, and that a considerable contribution to that non-compliance has to do with transference-related responses to the medication to the prescriber, I think we can greatly increase compliance with medication by some well-timed and well-directed, dynamically informed interventions. So even from a strictly pharmacological perspective, psychodynamic knowledge and skills are helpful. Second, I was recalling your comment about one of the advantages of managed care being a second opinion. And I agree with you that a second opinion is important in our practice. But I think that when we think of a second opinion, we're usually having in mind a physician whose interest is also in providing good patient care and helping the patient. That the patient's health and well-being is the primary interest. Where here that, in my experience, is one of the furthest things from the minds of these people, which is basically how to cut costs and keep the money from themselves instead of giving it to pay for health care.
I'll start with the second. You're totally right, and of course the system as it's operating now has no concern with quality and is concerned only with cost control, and therefore the second opinion is only a way of diminishing utilization rather than optimizing utilization, for most companies at least. But that's an artifact of where we are in the time course and of our failure to develop quality outcome measures that are publicly accessible and useful. I think in time, a more routine strategy of consultative review would enrich the profession and would be attractive to those who are interested in optimizing cost-effectiveness ratios rather than merely controlling cost. It would have to be by somebody more competent in general than the practitioner. The person at the other end of the phone should be your training director rather than a high school graduate.
Oh no, not that.
Not that, Jenny. Your first comment, you're repeating what was said before, and I'm not usually in the position of saying I don't think psychiatrists should learn more psychodynamic psychiatry. I think a psychiatrist should know the psychodynamic psychiatry that would be useful in understanding the dynamics of noncompliance and the appropriate management of it in a patient who's in a pharmacologic treatment regimen. That's not dynamic psychotherapy. That's a basic understanding of psychodynamics. My own view, though, is that I'm in no way convinced it's more important for the psychiatrist than the internist to have that knowledge. That's a fundamental knowledge base of clinical medicine. And in my experience, the management of chronic medical disorders, patients on renal dialysis or with diabetes or with rheumatoid arthritis, draw on at least the requirement for psychodynamic understanding on the part of the caretaker as the patients with chronic psychiatric disorders. In fact, my impression is more so, because they meet my early requirement. They're usually mentally healthier. And don't forget, this treatment works better for people who have more mental health to start with.
Thank you very much,
Jen,
Bob.
thank you.
Dr. Leston Havens.
Just a bridging comment, because my own remarks are at a very different territory. But a bridging comment. I thought that was a remarkable review of our problems and our opportunities and our difficulties of all kinds. I have one quarrel with Bob's comments, and it will be evident from my remarks, but let me say it clearly so that it's in the forefront. I believe that psychological psychiatry, dynamic psychiatry, call it what you will, it is just getting underway, and that we know very little about it, and that none of us are practicing at a level that would be regarded as even minorly respectable in 20 years from now or 30 years from now. And the tragedy of the present situation in psychiatry is that the opportunities to make the future work psychologically sophisticated and capable may be cut off, not only by managed care, but by the predominance of other points of view within psychiatry itself. Now, I'll try to make good on that by showing a way in which I believe, at a very simple level, our work needs to be improved. Our psychological work needs to be improved. The title we were assigned was, "Are We Still Talking?" And of course, what is equally important, are we still listening? And the part of that, the part of talking and listening that I want to address is what I believe is likely to be a central issue as our field develops. That is, I want to address the problem of talking and listening as I see it coming at us as we try to sophisticate and develop our medical responsibilities. Now, I want to address this by reviewing first some central developments within the history of medicine itself, some transition points within the history of medicine, and suggest analogous ways of talking and listening by which we might undergo some transitions of our own into a more effective psychiatry. Let me describe 3 transitional periods in the development of modern medicine. The last of these 3, very extended. I was told in my residency in medical school period that the systematic neurological examination dated from the introduction of reflex testing with a hammer and afferent pinprick testing. Thereafter, after the development of that systematic examination, areas of healthy and defective effector and affector function could be separated and delineated. The neurologist was no longer so dependent on the patient's reports. A similar transition took place in the history of cardiology with the introduction of percussion and auscultation. The almost exclusive dependence on patients' reports and on the pulse were put behind, and the heart and larger vessels made available for the delineation of normal and abnormal anatomy and function. My third example, endocrinology, has been so long separated from the humoral theory from which it arose that it is easy to lose sight of their very great similarities as well as differences. They are united in their concern for certain fluids affecting health. They are separated by what we can call procedural controls. That is, a named fluid has been replaced by specific cells and fluids that are respectively visible and measurable. A theoretical entity becomes determinable by quantitative test procedures. Now, I mention these transitions to highlight the present state of our own work and to suggest some steps, some preliminary steps toward a similar transition of our own. At present, psychiatry uses theoretical entities, syndromes or putative disease states, and unconscious complex and defenses on the one hand, and on the other, patients' reports and associations largely determining whether the theoretical entities are thought to be present. There are no routine clinical procedures, besides patients' reports, separating normal from abnormal responses. At bottom, I am saying we cannot pretend to be medical and scientific while using the practices of medicine before it was scientific. This problem has been known to us for a very long time and has prompted, of course, the search for blood and brain tests of pathological phenomena. It was also one motive for the development of psychoanalysis. Freud believed that patients' conscious reports were contaminated by unconscious distortions and therefore sought associational material that might be more revealing. But here, too, testing procedures eluded practice. The same judgment might be made of surgery, were there not a highly developed visual pathology as well as microscopic pathology for the difficult instances. The surgeon has much to go on in deciding what to cut, what is sick and what is well. I am suggesting that the scientific development of psychiatry depends upon the use of routine testing procedures, perhaps at first on the model of reflex testing or percussion. We may find, and I predict we will find, we may find that it is impossible to apply even sophisticated chemical tests and even brain imaging unless we first have the concepts and means to circumscribe entities and pathological processes. And if we did have those means, what a boon it would be, what a relief to patients and to our relationship with patients. Without clear means of separating normal from pathological functions, there tends to be a creeping pathologization of all psychological phenomena, so that we speak in our field adjectively of schizophrenic or agoraphobic patients as if that's all they were, in striking contrast to general medicine. And, of course, as a result, an increased defensiveness, or often resistance, on the part of patients. Stigma, I am saying, is partly our own creation. I want now to describe some readily applied testing procedures for clinical use. I will illustrate their application in the evaluation of affect states and states of will. In their accuracy and reliability, they seem to me at the level of percussion and auscultation. Certainly as I used to practice auscultation and percussion. The first of these procedures was initially described by me in two books, Participant Observation in 1977 and Making Contact in 1986, for the purpose of refining psychotherapeutic methods. I'm here extending and applying them for evaluative purposes. Patients' reports of their affects, so central to diagnostic work, need to be tested for the degree of fixity and depth of the affects, because much can sound alike in reported accounts that prove strikingly varied. I refer to the methods suggested here as empathic statements.
At this point, the program continues on side 2.